This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I'm Mariana Parks, physical therapist and your host, and today I share my conversation with Jared Powell, where we talk about frozen shoulder. In our discussion, Jared covers what frozen shoulder is, how it develops, common symptoms, at-risk groups, and key diagnostic methods, how to distinguish frozen shoulder from other conditions with similar symptoms, treatment options, the role of physical therapy in the use of injections and medications, and also we address misconceptions, identify outdated treatments, and discuss research in frozen shoulder care. Jared's a physical therapist with expertise in the shoulder complex. He holds a PhD in this area from Bond University, where he is also a visiting lecturer. He has authored book chapters, peer-reviewed articles, and presented at conferences. As a clinician scientist, Jared runs a telehealth shoulder practice, educates clinicians on shoulder pain, and continues to actively research in the field. If you find our conversation informative, please subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share this episode with colleagues who might benefit from these insights. Thank you for tuning in, and let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Sarah Health. Remote therapeutic monitoring sounds great, but also difficult. Sarah Health makes RTM simple and easy for your patients and providers. Check out sarahealth.com/PTProTalk for a special offer. Neck care.
Treating neck impairment? Get objective neck assessments with the Neck Care system. Learn more at neckcare.com.
Hi Jared, welcome to PT Pro Talk. How are you today?
I'm good, Mariana. Thanks for having me.
Awesome. I'm glad to finally have you here. So let's get started and talk a little bit about yourself and your journey.
Okay, so I'm a physio. I'm from Australia. I have just completed a PhD in managing shoulder pain. So that's been a long journey, but I'm glad it's finally done. I teach other health professionals, physios, chiros, osteos about shoulder pain as well. I do that through an online course and also face-to-face teaching. And I also run a telehealth business where I see people with complex shoulder pain conditions from all around the world. And that's what keeps me busy professionally. Personally, I am a husband and a father to two beautiful boys. And I like to run and lift weights and surf and try and lead an active, healthy lifestyle.
Busy life.
Busy life.
That's awesome. Before we continue our conversation, I wanted to take a quick moment to present you to our sponsor, Urban Pulling.
Welcome, PT Pro Talk listeners. Looking to enhance your rehabilitation practice or promote active aging? Urban Pulling Inc. has you covered with our evidence-based activator polls and program, trusted by over 10,000 therapists worldwide. These unique polls, designed by an occupational therapist, improve stability, posture, and mobility for individuals with conditions like Parkinson's, stroke, arthritis, and ortho rehab. Visit urbanpolling.com/PTProTalk and enjoy an exclusive 30% off on CEU-approved courses and 20% off for activator polls.
And now, let's get back to our conversation. So let's jump to our topic, frozen shoulder. So what is it and how does it typically develop?
So frozen shoulder in its simplest form is a painful and a stiff shoulder, basically. So that's how I would define it. It typically starts off as being a painful shoulder, and in the initial phases, it's actually pretty hard to differentiate from other shoulder pain presentations. We can talk a little bit about differential diagnosis later on. But then after maybe 6 weeks, a couple of months, this characteristic stiffness starts to develop, and that's really what separates it from other shoulder conditions. And it's the stiffness that sort of defines frozen shoulder once it's taken hold. How does it develop? It's a bit of a mystery. There's lots of different theories about how it develops or why it develops. It could be after a trauma. It could be after surgery. It could be after experiencing other forms of shoulder pain. But then the most common form of frozen shoulder is what we call a primary idiopathic frozen shoulder. So idiopathic means without cause. So there's literally no explanation for why it may occur in some people, which is a little bit hard to deal with if you're a person with frozen shoulder and you want to know why you have this condition all of a sudden. As a clinician and as a healthcare worker, it's hard to give an explanation. We don't know why you have it, and that can feel a little bit empty sometimes for people with a diagnosis of frozen shoulder. So it's really important to communicate what we do and do not know about frozen shoulder, but most importantly, the prognosis of frozen shoulder. And so even though we don't know why it may occur, we know a lot more about the pathophysiology, about sort of how it is occurring, and we know a lot about the natural history of frozen shoulder, and we know it tends to get better over time. They're not going to be stuck with a frozen shoulder for the rest of their life. There are some things that they can do for it, which I'm sure we'll talk about later on. So yeah, that's frozen shoulder in a nutshell.
Yeah, so the symptoms, the most common symptoms, so it's first pain and then stiffness. That's
it's usually like excruciating pain at the start. It's severe, unrelenting pain. It's often affecting their sleep. You can't get into a comfortable position at nighttime, which might be different from a rotator cuff related shoulder pain presentation, for example. So it's this like unremitting, unrelenting shoulder pain. And then gradually that morphs into a stiffness. And so we tend to delineate frozen shoulder as being in two different stages. It's pain greater than stiffness or stiffness greater than pain. And so in the initial phases, it's the pain is more than the stiffness. And then in the middle and latter stages, its stiffness is more profound than the pain. And so that the initial pain is horrific, when we do qualitative studies on people with lived experience of frozen shoulder, some seriously dark thoughts go through the minds of people with frozen shoulder. So it's important that we, have a really sympathetic and empathetic attitude with these people. And then once that stage tends to reduce or diminish, and then that stiffness starts to become more prominent. And that's also really functionally limiting as well. People are stuck with almost 0 degrees of external rotation, maybe 30 to 60 degrees of arm elevation, profoundly limited in their range of motion of the shoulder.
And is there like a common timeline for each phase, like the painful and the stiff?
It kind of varies. I don't like to say, look, you're going to have pain for 3 months, stiffness for a year, and then it's going to thaw out over 3 to 6 months. That's what we were taught at university. I think the stages overlap significantly as well. So it's really hard to give a firm timeline, but I give a guideline in saying the pain is going to be pretty bad for the first 6 months, and then it's going to be stiff for 6 months to a year, and then it's going to start to gradually get better over the next 6 months to a year. Like overall, it's generally a 2.5 year process of fully resolving the signs and symptoms of frozen shoulder. People will experience significant benefit over a year, but there'll still be some limitations at the end of that 12-month period.
Okay, so if you think about natural history, would say it would take about 2 years to resolve.
Yeah, exactly. And that's it. And I say it's got a favorable natural history, but it doesn't fully resolve. Some people have frozen shoulder 4 or 5 years later, even some evidence suggests up to 9 years later. So I don't think that we should just sit there and say it's going to get better by itself as clinicians. I think we should actively treat it. Again, I think we'll talk about treatment a little bit later. So I think there is a significant role for physiotherapists and healthcare professionals to play, and we shouldn't just say, oh, do nothing, it'll get better by itself.
Mm-hmm. Mm-hmm. And is there any risk factors, any known risk factors or triggers or anything like that?
Yeah, so it seems to primarily affect people who are aged between 40 and 60 years of age, almost exclusively. I've seen a couple of people younger than 40 and a couple of people older than 60, but it's almost always within that 40 to 60 age bracket, most commonly around that 50 years of age. In fact, in Japan and China, it's called the 50-year-old shoulder instead of a frozen shoulder. So the average age is about 50 to 51, I believe. So that's the first thing to look out for. If somebody's coming to your clinic, they're 50 years of age, they have a painful and stiff shoulder, you're already starting to think that perhaps this is a frozen shoulder. It seems to affect women more than men, but men certainly do get frozen shoulder. So it's not just a condition that affects women. I think it's like maybe 55 to 45% women get it more than men, but it's still really common in men as well. It seems to be associated with diabetes as, a comorbid condition. I think there's data out there that suggests that if you have type 1 diabetes, there's there is a 70% chance that you'll develop a frozen shoulder in your lifetime. So that's a pretty significant risk factor. It's also associated with thyroid issues, both hyper and hypothyroid issues. It's associated with Dupuytren's contracture of the finger as well. And I think it shares a fairly similar pathophysiology to Dupuytren's contracture. So that's what I would look out for. I'd look out for age, perhaps a little bit more common in women. And if they started saying they have diabetes, especially type 1 diabetes, then these are risk factors that would start me thinking that person may have a frozen shoulder.
Mm-hmm. And when you say that could be caused also by trauma or surgery or other forms, comparing to the idiopathic one, I would think that probably the trauma and surgery are less common.
Yeah, most often it's this primary idiopathic frozen shoulder. We don't know exactly how often, but the secondary frozen shoulder is a little bit more rare.
And do you see the same evolution as the primary?
Yep. Once it manifests, it's a very similar natural history.
Okay.
I will say though, a diabetic frozen shoulder is a little bit more tricky to manage, takes a little bit longer, and is a little bit harder to treat because there's other sort of systemic issues going on that seems to affect the natural history of a frozen shoulder.
Okay. And so how do you diagnose that? What tests, what you're looking for in your assessment?
Yeah, it should be a clinical diagnosis. So we shouldn't need to refer for imaging or for blood testing or anything like that. It should be made in clinic, and a physiotherapist should be upskilled enough to do that diagnosis. And it's in my opinion, a frozen shoulder is one of the easiest conditions to diagnose. And I get a little bit frustrated when I see so many frozen shoulder diagnoses getting missed. And not just by physios, by general practitioners as well, by all sorts of healthcare professionals. Mostly what happens, unfortunately, is that somebody goes in with shoulder pain, they see their GP, they get an ultrasound of their shoulder. The GP doesn't really assess what's going on with their shoulder. They just send them for a scan. The scan shows they've got a rotator cuff tear or subacromial bursitis, and then that person is treated for a rotator cuff tear or subacromial bursitis, when in fact this person has a raging frozen shoulder. They're profoundly stiff and limited into external rotation and abduction and internal rotation. And these findings on an ultrasound, such as a rotator cuff tear or subacromial bursitis, is just an incidental finding. It's a red herring. So if somebody comes in, they're aged between 40 and 60, they've got significant shoulder pain at rest, they've got minimal external rotation, and this is looking at their passive range of motion, not their active range of motion. So if they've got minimal passive range of motion, that's not better than their active range of motion, especially into external rotation, abduction, and internal rotation. That for me satisfies the criteria of having a frozen shoulder. If somebody comes in, they're limited with active range of motion, but they've got full passive range of motion, then it is highly unlikely that person has a frozen shoulder. So this The characteristic finding is an equal resistance or restriction of passive and active range of motion, primarily into external rotation, abduction, and internal rotation. So that is the diagnostic workup that you need to do. Now, if you're unsure, you can certainly get some imaging, an MRI of the shoulder, and an MRI of the shoulder will show up some high intensity signal, particularly in the rotator interval, the axillary recess, and generally at the anterior inferior capsule. But that's more just to confirm what you already think. Not everybody needs routine imaging. There is an argument, and this is a bit of a tangent, there was an argument, or there is an ongoing argument in the literature, whether everybody with a frozen shoulder should get a plain radiograph X-ray to rule out a sinister pathology of the shoulder, because the two can present quite similarly, often severe pain and stiffness of the shoulder. But there's been some interesting studies done, or a couple of studies off the top of my head done, that show that those with a suspected frozen shoulder rarely have, like we're saying, less than 1% of the time, people with a suspected frozen shoulder have a sinister pathology underpinning their shoulder pain presentation. So it's sort of uncertain as to whether we need to rush out and expose somebody to an X-ray if it is so rare that a sinister pathology is masquerading as a frozen shoulder. So my routine practice is not to refer everybody with a frozen shoulder for an X-ray. However, I always remain vigilant, and if I'm starting to become concerned about their general health, they start losing weight, perhaps they have a history of cancer or things like this, then I'm much more amenable to getting an X-ray for that person.
Yeah. And on the painful phase that you mentioned, would still the same apply on the range of motion? That would be limited passive as well, or would that develop later on?
Yeah, no. So in the first few weeks, maybe month, 6 weeks, it's hard to differentiate between an evolving frozen shoulder and just an irritable shoulder, perhaps due to a full thickness rotator cuff tear or something like that. So in that scenario, you have to rely on the demographic features. Is that patient aged between 40 and 60? Is it really sore at night time? Is it not getting better over time? Is there no position of comfort? So on and so forth. But it can be really hard to differentiate in the first month to 6 weeks, whether it is an evolving frozen shoulder or another shoulder pain presentation. You just need to give it time and see how it evolves. But as soon as I start to notice some form of stiffness coming into it, and then I'm very quick to diagnose it as a frozen shoulder and proceed down that pathway, because I think that how we manage somebody with a rotator cuff related shoulder pain presentation and a frozen shoulder presentation are very different, and that diagnosis needs to be made very quickly.
Mm-hmm. And about differential diagnosis, do you have any comments or things that we should pay attention with conditions that can mimic the frozen shoulder? Yeah,
so the condition that will mimic or masquerade as a frozen shoulder is glenohumeral joint osteoarthritis, and that's again quite common in that age group as well, maybe a little bit older. So if somebody's coming in their late 50s or early 60s and they've got crepitus or catching and clunking in the shoulder, you might start to suspect osteoarthritis over a frozen shoulder. It's a pretty simple thing to rule out. If you're suspecting osteoarthritis, just go and get that X-ray, and that'll show whether they've got osteoarthritis or not. If you rule out osteoarthritis, then you're starting to think about a frozen shoulder. The other common things that you want to rule out is a locked dislocation. So it's a glenohumeral joint dislocation that comes out but hasn't been relocated properly, and that can masquerade as a frozen shoulder as well. And the other thing which we've touched on previously is sort of a sinister pathology such as cancer that is masquerading as a frozen shoulder as well. And again, a CT scan or an X-ray is sufficient to rule out a sinister pathology as well. But again, exceedingly rare are those presentations. Lock dislocation and a neoplasm, for example, of the shoulder are really, really uncommon. I think in my entire career, which is now over 15 years. And I've been seeing shoulder pain patients exclusively for the last 7 or 8 years. I've seen one person with a frozen shoulder who has a sinister pathology, and I haven't seen any with a locked dislocation. I've seen lots with a glenohumeral joint osteoarthritis presentation though.
Okay. And now going to the treatment. So in your opinion, what are the main options available and differentiating on painful and then stiff?
Yeah, so there's a few different options. Non-surgical management is the primary management. So that's physiotherapy. And so what would a physio do if somebody comes in with a frozen shoulder? The evidence would say that some form of supervised or home exercise program in conjunction with the intra-articular corticosteroid injection is probably the most evidence-based recommendation to give to somebody with a frozen shoulder. So not everybody will want a corticosteroid injection, so that's something that you need to consider, and certainly physios often don't do the injection themselves, so you're probably going to want to refer that person back to their GP for a conversation about that. But I'm very quick to mention the evidence of a corticosteroid injection into the shoulder, and I don't exactly encourage people with a frozen shoulder to get an injection. I mention it and I say it's helped a lot of my patients in the past. If you're willing to get an injection, I would certainly support you in that journey. And in my anecdotal experience of being a shoulder expert physio for a number of years now, more times than not, these intra-articular injections are really helpful. And they're helpful in diminishing the pain experience. They don't change the stiffness profile often, so that stiffness often remains. But typically, the patients sleep better at nighttime and they've got a little bit less pain, which is an absolute relief when you've been suffering 24/7 with shoulder pain for months and months and months. And then it's about some form of supervised or home exercise program. And it's the exercise program is going to be guided by the patient. Where are they symptomatically? How irritable is their shoulder pain presentation? Initially, in the painful phase, you're not going to be able to do much. So it might just be very gentle range of motion exercises. You know, the old pendulum exercises and things like that still have a place for people with really severe frozen shoulder. And then once that pain starts to get better, then you'll start to treat the frozen shoulder patient almost like any other shoulder pain. You'll start some resistance exercise. It might start easy with some isometric exercise and then some more isotonic exercise. And then once the stiffness starts to get better, you can start with some overhead exercise, so on and so forth. So I think once you're actually starting your exercise program, you're guided by the patient, not by the frozen shoulder. You're guided by what they can and can't do and their goals for what they want to be able to do at the end of it. And it won't actually look that much different from any other shoulder pain presentations.
So you would try to see what they can tolerate. It should not become more irritable, or they shouldn't be worse the next day. Like, do you have a way to?
Yeah, exactly. I'm not aggressive in the initial phase, because it is a highly inflammatory condition that can be provoked quite easily with too much exercise or too much stretching, like vigorous stretching, for example. If you go back 20 years, 25 years, 15 years even today, actually, some therapists will advocate for very aggressive stretching and manual therapy in a frozen shoulder. And I don't tend to agree with that. I really think we can do more harm than good. And there's not a lot of evidence that aggressive stretching and aggressive manual therapy and aggressive range of motion exercise is actually going to shorten the time course of having it. You're just going to make their life worse in the short term for no benefit in the long term. So I don't see much reason for doing that.
Mm-hmm. Before we continue, I wanted to share something exciting with you. If you are looking to deepen your understanding of pain mechanisms and treatment strategies, I highly recommend the Role of Hurt course. I took this course myself, and I can tell you it was fantastic. Annie and Melissa are incredibly engaging, and the content is truly top-notch. The course titled Role of Heart Nociceptive Pain Mechanisms, Mechanical to Functional Exercise Prescriptions is happening on March 8th and 9th in Hillsboro, Oregon. As a special bonus for my listeners, you can get $50 off with the promo code WOHPTProTalk. Don't miss out on this opportunity to learn from the best. Visit Eventbrite and search for Role of Heart to register, then use code WOHPTProTalk at checkout. Now, let's get back to our discussion. Any suggestions on like maybe working the other shoulder to like radiate or neck, modulate pain or other?
Yeah, I recommend just keeping up with general exercise. Keep going for your walks. Keep trying to do general exercise, which has an anti-inflammatory component to it. So the last thing you want to do with a frozen shoulder is to just cease all forms of physical activity. You start to put on weight, etc., etc. This tends to have a more inflammatory effect because you're already not sleeping, so that's going to affect your pain system as well. So try as best as you can to live a normal life. I know it's easier said than done. I haven't had a frozen shoulder before, so I don't know how it feels. But as best you can, I encourage people to keep going to the gym, keep doing legs, keep working out the other side, keep doing some gentle exercise on the affected side, keep doing as much as you can do. You can't damage the frozen shoulder by moving it or using it, but you've just got to find the right dose that doesn't make you worse, but doesn't mean you're giving up altogether on exercise as well.
Mm-hmm. Okay, so it's mainly active exercises.
I think so. Yeah, like just general cardio is really helpful, I think, at keeping that person going, keeping them generally healthy. You can certainly exercise the other side as well, and perhaps that may have some crosstalk in terms of reducing atrophy and strength loss, etc., etc.
Mm-hmm. Anything else, in your opinion, that us as physical therapists could do to help that patient in the recovery?
I think the best thing we can do is advice, education, and then the provision of an exercise program. Like advice and education is so important in a frozen shoulder because there is no quick fix, sadly. There's nothing that we can do in a week or two that's going to make their shoulder pain substantially better. And that's just the way it is. So we need to have honest conversations about that. And honestly, a person with a frozen shoulder typically doesn't mind because they've often had pain for months and months and months. All they want is an accurate diagnosis. They want an honest prognosis. So they want, okay, I may have this for another year. That's okay, as long as I know it's going to get better, and maybe there's something I can do in the meantime that's going to help me manage the pain and perhaps make a speedier recovery down the line. And that's usually with an intra-articular injection followed by keeping the shoulder moving. There's a little bit of evidence for maybe down the line some glenohumeral joint mobilizations, so some, the classic anterior-posterior mobilizations of the glenohumeral joint and posterior anterior mobilizations of the glenohumeral joint. I don't think they're working via, like the mechanism isn't working through stretching the capsule. I don't think that's plausible or biologically possible, actually. I think a mobilization is working through some sort of pain modulation, central nervous system mechanisms. So we're not stretching the capsule when we do these mobilizations. We're just modulating that person's sensitive nervous system, I think.
Yeah. No, it makes sense. I was listening to your podcast with Jeremy Lewis a while ago that you were discussing exactly that topic.
Exactly. Yeah. We need like thousands of kilograms of force to stretch a capsule. And especially in a frozen shoulder, the capsule is fibrotic, and it's so like it is impossible to stretch with our human hands. So I wouldn't try and do it, and I wouldn't think we're doing it either.
Yeah. And like, how about the exercises? Do you think the exercises have an effect on that? Like it would speed up the recovery or like help the stiffness in any way? Or are you just trying to keep them active and keep them motivated?
Yeah, it's a good question. I don't know if biomechanically an exercise is doing anything to the pliability of the capsule. maybe exercise is having a specific, like resistance exercise, for example, maybe having some sort of local anti-inflammatory effect on the shoulder capsule. That's a possibility. I reckon it's probably having a psychological effect as well. It's keeping that person engaged, using their shoulder, not developing kinesiophobia or fear avoidance. It's improving their confidence to move their shoulder, perhaps increasing their self-efficacy. All of these things going into that sort of complicated web of why exercise is working for somebody with shoulder pain. So to answer your question, I'm not sure what it's doing or how much it's doing, but I think it's doing something valuable. We're just not sure yet, and that's a field of evolving research and ongoing research.
Better than not doing anything.
I think so. Yeah, I still encourage people with a frozen shoulder to do something rather than just see how it goes over a couple of years. Certainly, they can if they want. Like natural history is a fine way for people to go about dealing with a lot of musculoskeletal problems. I think the evidence probably says that doing something for it is a little bit better than doing nothing for it, though.
Yeah. And related to the pain, I know you said the injections. Other than the injections, anything else that you see working to help reduce the pain?
Yeah, so just like you can get your general pharmaceuticals. Lots of people like to take anti-inflammatories and just generic paracetamol. There's like an evolving class of drugs that are starting to be experimented with and might be coming out. Or might be more available or accessible to patients, like more anti-immune or immune suppressing pharmaceuticals, because we know the pathophysiology of frozen shoulder seems to be this immune mediated response where there's this like cytokine inflammatory storm, and we see a lot of immune mediated chemicals going on in there as well. So perhaps like anti-tumor necrosis factor medication and a bunch of different convoluted names out there as well might be coming out. And I think that might be the future as well, where there's like very specific immune suppressing drugs that may become more accessible to people with a frozen shoulder. But at the moment, I think it's still pretty experimental and hypothetical, and it's certainly not a mainstream treatment at this stage.
Mm-hmm. And like talking to therapists and teaching courses and with your experience, what do you think are very common misconceptions that people have about frozen shoulders?
So frozen shoulder is probably more common than you think. It's something that you should rule out. Like you should have it in the back of your mind. If somebody comes in, they're aged between 40 and 60, they have a painful shoulder. You've got to keep in the back of your mind that this may be evolving into a frozen shoulder or already is a frozen shoulder. So a rotator cuff related shoulder pain presentation is still the most common, like 70 to 80% of the time. But you're still going to see your fair share of frozen shoulders in clinic. So just don't be too quick to dismiss them. Another common misconception is that that you can treat it quickly with manual therapy or with specific exercises. I really don't think the evidence supports that. So when you're on Instagram and you're seeing crazy people like manipulating a shoulder or banging it with a hammer or rubbing it aggressively with some tool, don't do that. That is entirely unsupported. You're going to be causing more harm than good in that individual. And also, if you're a therapist and you treat somebody with a frozen shoulder and they're better in 2 weeks, that person didn't have a frozen shoulder. I can guarantee it. So that's a huge myth and misconception. They're going to have it for months and months and months and months. And you can still reduce that time frame, I think, but it's not going to be days or weeks. It's going to be months and months and months. And unfortunately, that's just the way it is. I hate to be the bearer of bad news, but that's reality. So they're the common myths and misconceptions, I think, around frozen shoulder. One, that it's rare. One, that it's really easy to treat and it takes a few months. And another is that we can treat it aggressively with magical tricks and exercises. I think that's a huge myth.
And you stretch the capsule.
Yeah, exactly. Yeah, even if you're the strongest person in the world, you ain't stretching that capsule.
Yeah. And regarding research, any like advances in treatment or anything that you're excited about?
Yeah, so I think the pharmaceuticals are going to be that really specific immune suppressing or immune mediating pharmaceuticals are going to be really interesting in the future. I think that's going to be over the next 10, 20 years, something that could change the lives of people with frozen shoulder, because we understand a lot about the pathophysiology of frozen shoulder now, which is great. So 20 years ago, 10 years ago even, it was still a bit of a mystery, but we know a lot about how this condition progresses physiologically. So if we know that, then it's a very short step between developing a medication to sort of restricting or having an influence on that pathophysiological process.
Yeah. And just talking about surgery, have you seen many people like going for surgery? What are the results? Is that something that's done or not done?
Yeah, good question. I've had a few patients go in and have an arthroscopic capsular release, and they did well. So there's a really, the most famous study that's come out in the last few years is called the FROST trial, which is a great name, FROST, frozen shoulder. It was an excellent randomized controlled trial that compared a manipulation under anesthetic to an arthroscopic capsular release surgery to physiotherapy with an intra-articular injection. And all three of those groups had the same clinical outcome at 12 months, maybe 2 years. I think certainly at 12 months. I'm not sure if they followed them up for 2 years. And there were really no differences along the way at any stage between those three interventions. So look, a capsular release can help people, a manipulation under anesthetic can help people, but they don't outperform simple physiotherapy with an injection. And simple physiotherapy with an injection is a hell of a lot easier to access and probably a little bit cheaper with less adverse events, and it's a little bit less risky as well. So that's the biggest randomized controlled trial that's come out comparing physio with surgery, and surgery didn't seem to outperform for physiotherapy with an injection. So having said that, though, all three of those interventions are viable, and a patient is well within their rights to choose any three of those treatments.
Mm-hmm. I just assume PT with the injection will be the most cost benefit.
Yeah, well, that's it's important. It's interesting that you say that, because the manipulation under anesthetic was the most cost-effective treatment, which was interesting.
Really?
Yeah, so which is crazy, because it's not crazy. I mean, when you think about it, it kind of makes a little bit of sense, because it's just one surgery, and then that person does a little bit of, they are doing post-operative physio as well, remember? They're doing post-operative exercise. So it's sort of hard to delineate, mm-hmm. Is it the surgery or is it the post-operative exercise that they're doing? But interestingly, the manipulation under anesthetic was the most cost-effective, but I don't see manipulation under anesthetic becoming, the primary treatment for frozen shoulder, because it's a fairly barbaric procedure.
Yeah. And I was thinking about the injections, like early on, if there was a way, because you said that it's more clinically recognizing the patterns, if there was a way to recognize that early on, I guess it could help a lot more patients in that painful phase. Like feeling safe to refer them to get an injection when you're not 100% sure if that's going to develop into a frozen shoulder. Yeah,
I think so. I think getting an injection as soon as possible in that inflammatory phase is really important. And certainly the evidence says an intra-articular injection in the first 12 months is far more beneficial than not getting an injection in the first 12 months. So that's on us to recognize the people who may have a frozen shoulder and try and get them in for an injection if they're willing as soon as possible.
And like if they haven't developed that stiffness yet, do you feel confident to refer them to get an injection if they fit that clinical picture?
Yeah, I have done it a few times in the past. I've also been wrong a few times in the past when I think, this person may be getting a frozen shoulder, but they don't. So, yeah, I'm still a bit cautious in saying, hey, you're 50 years old, you've got significant pain at rest. I'm a little bit hesitant in saying go out and get that hydrodilatation or intra-articular injection if I don't see any signs of stiffness, because that person still may just have a highly irritable rotator cuff related shoulder pain presentation. And just remember, especially a hydrodilatation, it's a very painful injection. So submitting somebody to that if they don't need it is still risky business, I think. And, if we're physios, we should abide by this do no harm principle. And I think I'm still not ready to just throw somebody out if I don't think they have a frozen shoulder to get that injection.
Mm-hmm. Mm-hmm. Okay. And anything else that you'd like to let the audience know or that you want to help them understand about frozen shoulder that we haven't discussed that you think it's important?
Yeah, as a frozen shoulder is out there. People with frozen shoulder exist. They do get better. It's not this entirely mythological condition that it's made out to be. We don't know everything about it, but hey, we don't know everything about anything really in musculoskeletal healthcare. So frozen shoulder is just another one of those things. It does get better. Tell patients that it will improve by itself, and there are things that you can do to perhaps shorten its time course. Yeah, that's sort of the main things. It's an entirely manageable and treatable condition, and it's really hard because if you Google frozen shoulder, patients often they end up in these Facebook groups of people with frozen shoulder, and so they've just fed a lot of misinformation about it, and they're trying all these wacky, crazy interventions, and it's full on. So I would tell people with a frozen shoulder, don't research it on the internet. Trust me, this is a condition that we can treat. There are a couple of evidence-based interventions that we can pursue. In 12 months, you're going to be much better than what you are now. In 2 years, it'll probably be close to fully resolved. If you're doing your exercises, so on and so forth. So listen to the advice of healthcare professionals. Try not to do your own research. Don't go down a rabbit hole of these Facebook groups and try and fix it in a couple of weeks with non-evidence-based treatment. That'd be my advice.
Okay. And if therapists are looking to find more information about the topic, do you have anything that you recommend them?
I do. So I coincidentally, we just published a textbook, Frozen Shoulder, and that's I wrote a chapter. It's by Philippe Struff. He's the editor, and he's one of the world leading experts on frozen shoulder. And I wrote chapter, I don't know what chapter number it is, but it was on the clinical assessment of frozen shoulder. And yeah, it's a really valuable resource. And if you want to know more about it, go get that book. Otherwise, there's tons of research papers out there that you can read.
That's awesome. And any advice to clinicians that are starting their careers?
Yeah, so it's funny you ask. We just wrote a paper on this, Mariana. It's called Dear Newly Graduated Physiotherapists, Advice That We Wish We Had Received. So that has just come out in the Journal of Orthopedic and Sports Physical Therapy, and it's 5 or 6 dot points giving advice to new grad PTs that we wish we received when we were new grads 100 years ago. So go read that paper. It's a far easier reading that than me just regurgitating all the stuff that I wrote in the paper. And if you can't get access to it, send me an email and I'll send it to you.
Awesome. And I also know you have online courses, right? Would you like to just mention them to the audience?
Yeah, so I've got like a mammoth online shoulder course that's like 16 hours long, and it goes into literally every single thing regarding shoulder pain, from frozen shoulder to rotator cuff related shoulder pain to long headed biceps to unstable shoulder, etc., etc. It goes into everything, and you can find more about it at my website, which is shoulderphysio.com, which is nice and easy. And I think we've had like 2,000 students go through the course now, which is awesome. So yeah. If you want to have a look, go to my website, and there's a lot more information about it there.
Okay, and I know you're pretty active on social media as well, right? Where people can find you.
Yeah, I used to be more active. I'm a busy dad now, so I don't get tons of time to be hanging out on Instagram, but you can find me at shoulder_physio on Instagram and Jared Powell 12, I believe, on Twitter or X. And I have a YouTube channel as well. And I've got a podcast, the Shoulder Physio podcast, which I forgot about. And that's a pretty popular podcast. And if you finish listening to all of Mariana's episodes, go listen to some of mine.
Awesome. Very good. Jerry, thank you so much. Anything else that you want to plug in before we wrap up?
No, that's enough plugging. Thanks for the chat. It's been fun. And hopefully somebody or people can learn a little bit about frozen shoulder, because it's not that hard to understand. There's a lot of information that we have out there, but we've just got to make it more publicly available, I think.
Yes, that was a great review. So thank you so much for coming and taking time out of your busy schedule to help us understand the condition better. So I appreciate it.
Thanks for having me. Cheers.
That's all for today's episode of PT Pro Talk. We hope you enjoyed this discussion. Be sure to follow us wherever you listen to podcasts so you'll be notified when we release future episodes. You can also join our email list at ptprotalk.com to receive updates and access new episodes. If you have ever gotten value from the show, please take a moment to leave us a 5-star review. It always makes my day and it really helps us out. If you have any guests or topics you'd like to see on the show, let us know by answering a quick survey. You can find the link in the show notes, along with more information about our guests, resources, website, and social media. Thanks again for listening, and until next time.